Tubular reabsorption quickly reclaims most of the tubular contents and returns them back to our blood. So our selective transepithelial process, so going across the epithelium here. Okay. Almost all organic nutrients are reabsorbed. Now note, organic meaning contains carbon. Water and ion reabsorption is hormonally regulated and adjusted. It includes an active and passive tubular reabsorption. So substances can follow two routes. So we're going to look at transcellular and paracellular. Trans and para. So let's start with transcellular. So the solute enters that apical membrane of the tubule cells. We'll see pictures here in a moment. Travels through cytosol of the tubule cells, exits the basolateral membrane. So apical is going to be above, okay? Basolateral, think basement. Okay, so exits the basolateral membrane of the tubule cells. Enters our blood through the endothelium of the paratubular capillaries, the small little blood vessels. So remember, artery, arterial, capillary, venular, vein, capillaries. Number 2, our paracellular route. Between tubule cells, limited by tight junctions, but leaky in proximal nephron. So the nephron is going to be the parenchymal unit of the kidney, remember. Nephron, you'll see N-E-P-H-R as the word root meaning kidney here. So remember, like a nephrologist is the doctor that specializes in kidneys. Okay. So what are we looking at here? We're looking at water, calcium, magnesium, potassium, sodium in the PCT move via this route right here, this paracellular route. So looking at this nice picture here, okay, so we see our picture and we're going to see the numbers over here. So note 1, 2, 3, okay, 2 is a little fork in the road here, and then we've got 3 and 4. Okay, so our transport across that apical membrane. So here's the little finger-like projections here. Okay, so the little finger-like projections of the apical membrane. So we go through the cytosol. Number 2 diffuses through the cytosol here. Number 3 being a transport across the basolateral membrane. So that basement membrane here. Okay, so basolateral membrane often involves the lateral intracellular spaces because the membrane transporters transport ions into these spaces here. Okay. Number 4, okay, so we see our paratubular capillary here and our red blood cells here. Okay, so movement through the interstitial fluid and into the capillary. Okay, so remember, this is what's happening in our body anyways, right? All over our body. We have our blood flow, and then it's going out into the interstitial fluid and then comes in contact with our parenchymal cells. So remember, the blood doesn't come in contact with any of our parenchymal cells, okay? Okay, so the paracellular route involves movement through the leaky tight junctions. Here's the tight junctions. Okay, so movement through the leaky tight junctions, particularly in the PCT or the proximal convoluted tubule. Okay, movement through the interstitial fluid and into the capillary. Okay, here's our capillary. So tubular reabsorption of sodium. Sodium transport across that basolateral, that kind of basement membrane that we saw there. Sodium is the most abundant cation in filtrate, most abundant, sodium. Transport of sodium across the basolateral membrane of the tubule cell is via what's called primary active transport. So our sodium potassium ATPase pumps sodium into this interstitial space. Sodium is then swept by bulk flow into the paratubular capillaries that we just saw. Transport across that apical membrane. So that sodium enters the tubule cell at the apical surface, those little finger-like projections that we saw off to the left, via secondary active transport, or what we call co-transport, or via facilitated diffusion through the channels. So active pumping of sodium at the basolateral membrane results in strong electrochemical gradient within the tubule. So remember, electricity and chemistry, that's how our body's working most of the time. It's through electricity and chemistry. So results in low intracellular sodium levels that facilitate sodium diffusion. And our potassium leaks out of the cell into that interstitial fluid, leaving a net negative charge inside the cell, which acts to pull the sodium inward. So our tubular reabsorption of nutrients, water, and ions. So sodium reabsorption by primary active transport provides energy and means for reabsorbing almost every other substance. So secondary active transport is the electrochemical gradient created by pumps at that basolateral surface, give this push needed for transport of other solutes. Organic nutrients reabsorbed by secondary active transport are co-transported with sodium. So we're looking here at glucose, amino acids, some ions, some vitamins. Okay, so organic nutrients. Organic again meaning contains carbon. Passive tubular reabsorption of water. So movement of sodium. So we're always thinking about sodium and water. Okay, so water is going to follow salt. Okay, so water is always going to follow salt. So you move water by moving salt. Okay? So movement of sodium and other solutes creates osmotic gradient for water. That's what that means. Water is going to follow salts. So water is reabsorbed by osmosis, aided by water-filled pores called aquaporins. Note aqua being water, right? And pore, okay? Aquaporins. So we see this obligatory water reabsorption. So the aquaporins are always present in the PCT, but we call it facultative water reabsorption when we see the aquaporins are inserted in the collecting ducts only if ADH is present. Now, what is ADH? Antidiuretic hormone. What does a diuretic do? A diuretic makes the patient urinate more. So an antidiuretic is going to spare that water. Okay, so it's for blood pressure regulation. Passive tubular reabsorption of solutes. So solute concentration and filtrate increases as water is reabsorbed, creates concentration gradients for solutes, which drive their entry into tubule cell and paratubular capillaries. So our fat-soluble substances, some ions and urea, will follow water into the paratubular capillaries down their concentration gradients. For this reason, lipid-soluble or fat-soluble drugs and environmental pollutions are reabsorbed, even though we don't want to reabsorb them. Okay, so fat-soluble drugs and pollutants. Nice picture for us here. So our reabsorption by the PCT cells. Okay, so at the basolateral membrane, sodium is pumped into the interstitial space by sodium-potassium ATPase. Active sodium transport creates concentration gradients that are going to drive the following steps here. So we're looking at number 1 right here. So note the key down here. So this solid line, primary active transport. This dotted red line, secondary active transport. Solid blue, passive transport. And you can see solid blue right here for passive. You can see primary active right here and secondary active over here. Okay, so you can see some more passive transport lines along this way. And then the transport protein is this solid gray, ion channel here, and aquaporin here. See the water? Aquaporin. So back over here, okay, so active sodium transport creates concentration gradients that drive downhill sodium entry at the apical membrane, so number 2. So this is where those little finger-like projections were, remember, at the apical membrane, sodium. Number 3, reabsorption of organic nutrients, so our glucose, our amino acids, some ions, and vitamins. Okay, co-transport at the apical membrane here, apical membrane. Number 4, okay, number 4 right here, number 4, reabsorption of water by osmosis, which is the diffusion of water, okay, through aquaporins, those water pores. Water reabsorption increases the concentration of the solutes that are left behind. These solutes can then be reabsorbed as they move down their gradients. Lipid-soluble substances diffuse by the transcellular route that we just talked about. Number 6, various ions here. Okay, number 6, various ions, chloride, calcium, potassium, and urea diffuse via the paracellular route. Transport maximum. So transcellular transport systems are specific and limited. So we call it the transport maximum, or TM for short. It exists for almost every reabsorbed substance. Reflects the number of carriers in our renal tubes that are available. Okay? We can't carry more if we don't have enough carriers. Okay? When carriers for a solute are saturated, excess is excreted in the urine. Example, your blood sugar. Okay, so hyperglycemia leading to high blood glucose levels that exceed the transport maximum. We'll see blood sugar spill over. We'll see glucose spill over into the urine. We're not supposed to see excess glucose in the urine. Reabsorptive capillaries of renal tubules and collecting ducts. Proximal convoluted tubular, what you'll see as the PCT, site of most reabsorption. All nutrients such as glucose and amino acids are reabsorbed. We see 65% of sodium and water reabsorbed. Many ions, almost all uric acid. So when we think about the words here, uric acid, what immediately comes to your mind? Good. Gout. Hopefully you said gout, right? So about half of urea, which is later secreted back into our filtrate. Our nephron loop, so descending limb. Water can leave, solutes cannot. Ascending limb, water cannot leave, solutes can. This thin segment is passive to sodium movement. Our thick segment has sodium, potassium, 2 chlorides, symporters, and sodium hydrogen antiporters that transport sodium into the cell. Some sodium can pass into cell by paracellular route in this area of the limb, our paracellular route, remember. DCT, or distal convoluted tubule, distal, further away, convoluted. It looked like that old country windy road. Okay? And our collecting ducts. So our reabsorption is hormonally regulated in these areas. So think of ADH, or antidiuretic hormone. This is released by posterior pituitary gland. Okay, so we have our hypothalamus, where neural becomes endocrine, and then we have an anterior, sometimes you'll hear a middle. Okay, so anterior, middle, and posterior pituitary. So posterior pituitary is going to give us oxytocin and ADH. So this causes principal cells of collecting ducts to insert aquaporins, those water pores, in the apical membranes, the little finger-like projection side to the left on that picture, increasing our water reabsorption. Increased ADH levels cause an increase in water reabsorption. Aldosterone. Okay, so we think of aldosterone with sodium. We put a little N in front of the word here to associate sodium with aldosterone. Targets collecting ducts, or our principal cells, and distal DCT. Promotes synthesis of apical sodium and potassium channels. And basolateral sodium-potassium ATPase for sodium reabsorption. Water follows salt all the time, right? So very complex ways of moving water. Okay, so water follows salt. Okay, so as a result, little sodium leaves the body. So if little sodium leaves the body, a little water as well. Okay, so this is water sparing. This is going to increase our blood pressure and decrease potassium levels. Okay, without aldosterone, daily loss of filtered sodium would be about 2%, which is incompatible with life. ANP, or atrial natriuretic peptide, so it reduces blood sodium, resulting in decreased blood volume and blood pressure released by cardiac atrial cells, atria. Remember our atria and our ventricles? The top two are the atria, right and left atria. So atrial cells, if blood volume or pressure is elevated. Parathyroid hormone, those usually about four very, very small glandular tissue areas around the thyroid usually. Okay, so parathyroid hormone acts on DCT to increase calcium absorption. So parathyroid hormone helps regulate calcium, remember. Here's a nice picture that kind of pulls it all together for you. So if it works for you to draw this, you can redraw this, and you can see exactly where reabsorption and secretion are happening about what we were just talking about and going to continue to talk about. But a nice visual here for you if you like to study via drawing. So looking here, okay, so let's look at this table. So reabsorption capabilities of different segments of the renal tubules and collecting ducts. So we tubule segment right here, this is the PCT. So see how it's highlighted in yellow? Proximal convoluted tubule. Okay, so proximal, closest to, right? Convoluted, this kind of curvy shape here, and then tubule. So substances being reabsorbed here, sodium, virtually all nutrients, chloride, potassium, magnesium, calcium, bicarb, water, lipid-soluble solutes, urea. And then over here you can see the mechanism. So sodium, primary active transport. Other nutrients, secondary active transport with sodium. Okay, so the chloride, potassium, magnesium, calcium, some other ions, passive paracellular diffusion driven by the electrochemical gradient. Now, bicarb is a secondary active transport linked to hydrogen secretion and sodium reabsorption. Water, that's going to be osmosis, diffusion of water, driven by solute reabsorption, obligatory water reabsorption. So remember, water is going to follow salt. That's what this is saying. Water is following salt. Our lipids are fat-soluble solutes, passive diffusion driven by the concentration gradient created by the reabsorption of the water. Okay? And the reabsorption of the water follows salt, right? So our urea here, passive. Okay, so primary passive paracellular diffusion driven by chemical gradient. So the tubule segment here of our nephron loop, so this loop right here, okay, we have descending, so it's going down right here. Okay, so the direction is going this way. Okay, so descending. Okay. This is going to reabsorb water via osmosis. And then our ascending, this side over here, okay, coming up this way, our ascending, this is going to reabsorb sodium, chloride, potassium, calcium, and magnesium. So sodium, chloride, potassium, this is secondary active transport, okay, via sodium, potassium, chloride co-transport in the thicker portion. And let me get to the eraser here. So see how there is this thicker portion right here. Okay, so thicker portion right here. Paracellular diffusion, sodium, hydrogen antiport. Okay, and then our calcium and magnesium here. So passive paracellular diffusion driven by electrochemical gradient, so electricity and chemistry. DCT, or distal convoluted tubule. So this right here. Okay, so it's distal to the glomerulus. Okay, convoluted is the shape, and it's the tubule. So we're looking at sodium, chloride, and calcium here. So sodium and chloride is going to be primary active transport. Okay, so active sodium transport as basolateral membrane. Secondary active transport at apical membrane via sodium chloride symport and channels. So we see aldosterone regulated at the distal portion. So remember, aldosterone, main thing here is going to be sodium. Okay, so sodium aldosterone. So calcium, okay, so calcium here is going to be a passive uptake, okay, via parathyroid hormone. So remember the little, about 4 little pieces of glandular tissue right at the thyroid usually, okay, for calcium regulation. Okay. So via parathyroid modulated channels and apical membrane, primary and secondary active transport, antiport with sodium and basolateral membrane. This is why, you guys, when we have a patient that has kidney issues, we want to look at their parathyroid and vice versa. If they have parathyroid tumors, we want to make sure their kidneys are being well taken care of. And if their kidneys are having trouble, we want to make sure their parathyroid is being well cared for as well. And we really want to look at vitamin D with this component. Okay, so because both play a major role, kidneys and parathyroid both play a major role in vitamin D regulation. All right, so our collecting duct over here. Okay, so collecting duct, you can see it right here. We're looking at sodium, potassium, bicarb, chloride, water, urea. Okay, so the first 4 here, sodium, chloride, bicarb, and chloride, or sodium, potassium, bicarb, and chloride, primary active transport of sodium. So again, this is requiring aldosterone. Okay, so aldosterone and sodium going together always here. Passive paracellular diffusion of some chloride. co-transport of chloride and bicarb. Potassium is both reabsorbed and secreted, so it's aldosterone dependent, usually resulting in a net potassium secretion. So water here is going to be osmosis, of course, controlled facultative water reabsorption. So ADH is required to insert those water pores or those aquaporins, ADH aquaporin insertion, okay? Urea here, okay, so urea facilitated diffusion in response to concentration gradient in the deep medullary region or the middle area of that kidney, okay, the middle area of the kidney, not the medulla oblongata here, okay? Deep medullary region recycles and contributes to medullary osmotic gradient. Step 3, tubular secretion, is a reabsorption in reverse. It occurs almost completely at the proximal convoluted tubule. So selected substances are moved from that peritubular capillary area through the tubular cells out into the filtrate. So we're looking at our potassium, our hydrogen, our NH4, creatinine, organic acids, and bases. So remember, creatinine is going to be a kidney function test, so blood work. Okay? So creatinine and BUN are our two substances that we look at in the blood. Creatinine is going to be a muscle byproduct, though. So remember that creatine is going to help build up muscle. Creatinine is going to be the muscle breakdown, but it's a kidney function test because the kidney is supposed to filter it out appropriately. So if it's left in the blood in higher amounts than it should be, that means the kidney is not filtering it out. So it's a muscle end byproduct, but it's a kidney function test, okay? All right, so substances synthesized in tubule cells are also secreted. So example would be bicarbonate. Tubular secretion is important for disposing of substances like drugs, metabolites, okay, that are bound to plasma proteins. Okay, so when someone has low plasma proteins, we might see problems with drug metabolism and other metabolites. Okay? Eliminating undesirable substances that were passively absorbed, so think urea. So the other kidney test that we're looking at is blood urea nitrogen. Okay, so urea and uric acid is usually associated with gout. Okay, so you could have high uric acid levels, or you could have normal, what would have been normal uric acid levels, but the kidney isn't functioning appropriately. Okay, so there's a couple reasons why you might see a high uric acid level. It's either kidney dysfunction or an increased intake. Okay, so ridding the body of excess potassium, which is going to be aldosterone it's aldosterone's job, but aldosterone we always want to associate with sodium, but then there's the sodium-potassium connection as well, okay? If we see excess potassium, that's a really dangerous situation, right? So potassium is highly controlled. So if we see that, that's major kidney dysfunction at that point, most likely. Okay? Some drugs will do that too, but we're worried about a heart attack right there. So we're really worried about that. Of note, if you see a high BUN and a high creatinine, two kidney function tests, but we see a normal potassium, that says that the tubes are working okay. So that is very important for our patient's health because they'll be given a blanket statement of what they can and cannot eat. And we know that potassium is in a lot of really healthy foods, right? Fruits and veg. And they'll be told that they can't eat those things because they're not processing the potassium appropriately. So if you look at their blood work and that's normal, they can most likely still eat fruits and vegetables because the tubes are still working. Okay, so that's a very important distinction to look at and not just treat with a blanket statement. Controlling blood pH by altering the amounts of hydrogen and bicarb in urine. And you looked at this in your Draught Notes. Nice little picture here for you. If you like to draw that out, you can see the reabsorption and the secretion in the different areas. Regulation of urine, so concentration and volume. So number one thing our body is doing is it is regulating blood pressure. Okay, so that's why we will stop urinating when we're dehydrated in order to try and maintain a normal blood pressure. Right? Number one distinction there. One main function of the kidneys is to make any adjustment needed to maintain body fluid osmotic concentration at about 300 MOSM. Osmolality, number of solute particles in 1 kilogram of water. 1 osmol equals 1 mole of particle per kilogram of water. Body fluids have much smaller amounts, so expressed in milliosmoles. Okay? Kidneys produce only small amounts of urine if the body is dehydrated, or dilute urine if overhydrated. Accomplish this by using countercurrent mechanisms, so fluid flows in opposite directions in 2 adjacent segments of the same tube with a hairpin turn. 2 types of countercurrent mechanisms. Okay, so the countercurrent multiplier versus the countercurrent exchanger. So the multiplier, interaction of filtrate flow in ascending, descending limbs of the nephron loops and the juxtamedullary nephrons. Countercurrent exchanger would be blood flow in the ascending and descending limbs of that vasa recta. 2 countercurrent mechanisms work together to establish and maintain medullary osmotic gradient from renal cortex through medulla. The gradient runs from 300 MOSM in cortex to 1200 MOSM at the bottom of the medulla. So we see a countercurrent multiplier creates gradient, countercurrent exchanger preserves the gradient. Collecting ducts can then use the gradient to vary the urine concentration. Nice little schematic here for us. Okay, so juxtamedullary nephron create an osmotic gradient within the renal medulla that allows the kidney to produce urine of varying concentrations. Okay, so you see this big picture. So 3 key players interact with the medullary osmotic gradient. Okay, so long nephron loops of juxtamedullary nephrons create the gradient. They act as countercurrent multipliers. Vasa recta preserves the gradient. They act as countercurrent exchangers. The collecting ducts of all nephrons use the gradient to adjust urine osmolality. Good. Countercurrent multiplier, so this involves the nephron loop. Okay, it depends on filtrate flow in opposite directions, so that descending and ascending. Difference in permeabilities between descending nephron loop and ascending loop. Active transport of solutes out of ascending limb. Limbs of nephron loop are not in direct contact, but are close enough to influence each other's exchanges with surrounding interstitial fluid. So remember that interstitial fluid, as we see it, right? It's kind of like lymph, but interstitial fluid, if you had to define the difference between lymph and interstitial fluid is what came out of the blood first. It's got the good stuff in it, basically. And the lymph would be further down the line and have a little bit more of the garbage, if you will. Ascending limb of nephron loop is impermeable to water and selectively permeable to solutes. Sodium and chloride are actively reabsorbed in thick segment. Some passively reabsorbed in the thin segment. Our descending limb of that nephron loop is freely permeable to water, but impermeable to solutes. So ascending and descending are opposites. Countercurrent mechanism. So the more sodium chloride the ascending limb actively transports out into interstitial fluid, the more water diffuses out of the descending limb. The more water that diffuses out of the descending limb, the saltier the filtrate becomes. So the ascending limb then uses the salty filtrate to further raise the osmolality of the medullary interstitial fluid. So you can see the constant difference of the 200 MOSM always exists between these 2 limbs of the nephron loop and between the ascending limb and the interstitial fluid. Okay, the difference is multiplied, so we're a countercurrent multiplier. Okay, so difference is multiplied along the length of the loop. Really nice picture here for you, very similar to what you did with your draw it to know it. So go ahead and take a look at this. We'll see this kind of play out in these numbers in the next couple slides here. So our number 1, the filtrate entering the nephron loop is isoosmotic to both blood plasma and the cortical interstitial fluid. Okay, number 1 right here. Next, water moves out of the filtrate in the descending limb, descending, coming down here, down the osmotic gradient. This concentrates the nitrate. Next, filtrate reaches the highest concentration at the bend in the loop. Right here, you can see where it's 1200. Number 4, sodium and chloride are pumped out of the filtrate, and this increases the interstitial fluid osmolality. Next, the filtrate is at its most dilute as it leaves the nephron loop. At 100 MOSM, it is hypoosmotic to the interstitial fluid. Countercurrent exchanger utilizes the vasa recta, which is highly permeable to water and solutes. The flow of blood in vasa recta is also countercurrent, so it's a hairpin turn. So blood can exchange sodium chloride and water with its surrounding interstitial fluid as it moves through the adjacent parallel sections of the gradient. Blood inside the vasa recta remains isoosmotic with the surrounding interstitial fluid. So the vasa recta is able to reabsorb water and solutes without undoing that osmotic gradient created by the countercurrent multiplier. Countercurrent exchanger preserves medullary gradient by 1. Preventing rapid removal of salt in interstitial space, 2. Removing the reabsorbed water. Water in ascending vasa recta comes from descending vasa recta or is reabsorbed from the nephron loop in the collecting duct. As a result, the volume of blood at the end of the vasa recta is greater than at the beginning. And here's a nice picture for you here. Okay? We see sodium chloride, water, back and forth all the way down. Countercurrent flow of fluid moves through 2 adjacent parallel sections of the vasa recta. Okay? So on this side here, you can see the sodium chloride and water being exchanged. Sodium chloride coming in, water coming out. Opposite over on this side here, and it's coming up towards the vein here. Nice slide to study and redraw. Formation of dilute or concentrated urine. Okay, so how much water are you drinking? How much are you sweating? How hot is it? How much sugar, caffeine, diuretics, antidiuretic, and what's the blood pressure? Okay, so these are the things we want to kind of think about here. So established medullary osmotic gradient can now be used to form dilute or concentrated urine. Without gradient, we would not be able to raise urine concentration over 300 MOSMs to conserve water. So overhydration, drinking a lot of water, is going to produce a lot of dilute urine. Okay? ADH production decreases. Okay? If aldosterone is present, additional ions can be removed, causing water dilute to about 50 MOSMs. Okay? So of note, alcohol is an antidiuretic. Okay, so it sounds kind of like a double negative there, but it's an antidiuretic, so that's why it makes people urinate more. Dehydration produces small volume of concentrated urine, so maximal ADH is released. We'll see urine at about 1200 MOSMs. Severe dehydration, 99% water reabsorbed. And a nice schematic for you here. Okay, so if we're so overhydrated and we had no ADH, you'd see this decreased osmolality of extracellular fluids, decreased ADH release from post-pit, decreased number of aquaporins in collecting duct, decreased water reabsorption from the collecting duct, and a decrease, well, not decrease, but then a large volume of dilute urine. Okay. So you could see what's happening right here. So again, active transport's in red. Blue is passive transport. Okay, so we see the descending limb of the nephron loop, and out here is in the cortex, and here is medulla. Okay, so outer medullary and inner medullary. Okay, and then coming up and around. Good. If we were so dehydrated we had maximal ADH, we would see the opposite occur. Okay, so increase, 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 and then a small volume of concentrated urine because we are dehydrated. Urea helps form the medullary gradient. So urea enters the filtrate in the ascending thin limb of the nephron loop by facilitated diffusion. 2, cortical collecting duct reabsorbs water, leaving urea behind. 3, in deep medullary region, now highly concentrated urea leaves collecting duct and enters interstitial fluid of medulla. The urea then moves back into the ascending thin limb and contributes to the high osmolality in the medulla. Diuretics, so chemicals that enhance urinary output, so it makes you urinate more. So here again, ADH inhibitors like alcohol, it's an antidiuretic. Sodium reabsorption inhibitors like caffeine or drugs for high blood pressure or edema. Loop diuretics inhibit medullary gradient formation. Osmotic diuretics are substance not reabsorbed, so water remains in the urine. For example, in a diabetic patient, high glucose concentrations pull water from the body. Okay, so water is going to follow glucose, water is going to follow salt. So in a clinical evaluation of the kidney, so the urinalysis, urine is examined for signs of disease. So it can also be used to test for illegal substances. Assessing renal function requires both blood and urine examination. Example, renal function can be assessed by measuring nitrogenous waste in the blood only. To determine renal clearance, both blood and urine are required. Renal clearance, volume of plasma kidneys can clear of a particular substance in a given time. So renal clearance tests are used to determine the GFR, or the glomerular filtration rate, to help detect kidney disease and follow the progress of it. So here's the calculation for it. I'll never test you on the calculation for it. It's on the labs for you, okay? But you can look at it here if you like. And what are they using? Inulin. Yeah, plant polysaccharide is standard use, so freely filtered and neither reabsorbed nor secreted by the kidneys. Okay, so you could do this. Again, we don't really see this though. So we'll see a BU and a creatinine, and that'll calculate the GFR for you. So chronic renal disease defined as a GFR of less than 60, okay, for 3 months. Filtrate formation decreases, nitrogenous wastes accumulate in the blood, and the pH becomes acidic. So remember, if it becomes acidic, what's their breathing going to be like? Okay, so they'll start to try and breathe off, exhale off that acidity. Okay, so remember your metabolic and respiratory alkalosis and acidosis attempts at normalizing. And so we'll see this in diabetics. And also high blood pressure is going to damage the kidney. So these two diseases go together, right? So we see diabetics and high blood pressure go together all the time. And these patients are going to be at high risk for kidney dysfunction. Kidney failure, GFR under 15. Uremia. So this is ionic and hormonal imbalances, metabolic abnormalities, toxic molecule accumulation. Okay, symptoms, fatigue. Anorexia, meaning they don't want to eat. Nausea, mental changes, cramps. So what this looks like is, if you've ever been hungover, think of your worst hangover ever. This is what this looks like. Okay, so this is what that feels like for that patient. And treatment would be a kidney transplant, peritoneal dialysis, or hemodialysis. Heme being blood. So what are we looking at here? So we're looking at the chemical composition. So about 95% water, 5% solutes. We'll see urea from the amino acid breakdown. Right? We'll see uric acid from nucleic acid metabolism. So remember that uric acid being gout, associated with gout. And then we're going to see that urea and creatinine. So the creatinine being the metabolite from creatine phosphate. Creatine being muscle buildup. Creatinine, this one, is the muscle breakdown. Okay. So other normal things that you'll find in urine are right here. Abnormally high concentrations of anything is a bad idea. And you could see the nice table here. So if we see sugar, glucose in there, we'll call it glycouria, so urine, okay, sugar in the urine, and diabetes is what we think. Okay, proteinuria, albuminuria. So think albumin, think the egg whites is albumin. Okay, so again, this will be frothy in the toilet. Okay, and this can be heart failure, kidney failure, severe high blood pressure, kidney disease. Ketone bodies, ketonuria, maybe we're doing that on purpose. Maybe we're on the keto diet, okay? Or they have severe untreated diabetes. Hemoglobin, okay? Varies, transfusion reactions, hemolytic anemia, severe burns. Bile pigments, could be liver disease, bile duct, or again, liver gallbladder. Erythrocytes, that's red blood cells, okay? Hematuria. Bleeding urinary tract. So this is not an uncommon thing to see. Okay, so due to trauma, kidney stones, infection, or cancer, but this is the most likely thing. So a UTI. Most females have had a UTI before. Okay, because of the anatomy of the female GU tract, we'll see UTIs. Okay, leukocytes, pyuria being pus, pi. Okay, again, that's a UTI. Very common. So color and transparency of urine, so that'll be noted on a urinalysis or a UA, and they'll talk about it being clear or cloudy. Cloudy indicates UTI. Pale to deep yellow, okay, from urochrome, okay, urine color. Pigment from hemoglobin, so you did that hemoglobin quiz in video before, okay? So the heme breakdown. So yellow color deepens with increased concentration. Abnormal color being pink, brown, smoky. This could be foods, right? So beets notoriously will discolor the urine pinkish red, right? Bile pigments, blood, drugs. Okay, different things can cause different aspects of weird looking urine. Maybe somebody eats asparagus and they can smell it in the urine later, the aspergine. So the odor, okay, so like with the aspergine from asparagus, drugs, veggies may alter the smell, bacteria, diseases, diabetes, it could give it off an acetone smell to it, pH. So look at this range, okay, this is a pretty large range. It goes from acidic, 4.5, to alkaline, 8.0. So acidic diet proteins, whole wheat, okay, these can drop the pH. Alkaline diet can increase it. Okay, so prolonged vomiting, urinary tract infections. Specific gravity is the ratio of massive substance to massive equal volume of water. So specific gravity of water is a 1. So it ranges from this number to this number here because it's water and solutes. The ureters, you had this in GA, so it's here for you if you need it. So here's the ureters. Pretty cool looking picture there. Renal calculi, also known as kidney stones. Okay, so this could be calcium, magnesium, uric acid, salts, all sorts of different things for kidney stones. Different homeostatic imbalances, so UTIs, urinary retention, increased calcium in the blood. They'll do some shockwave lithotripsy. There's all sorts of ways to deal with this, though. Okay, so all sorts of natural ways to deal with a kidney stone. Urinary bladder anatomy, here it is to remind you, but I know you had it in GA. All right, so the urine storage capacity, it elapses when empty. We see the rugae, those are those ridges. Okay, so expands and rises superiorly during filling without significant rise in internal pressure. So a moderately full bladder is about 12 centimeters long and can hold about a pint of urine. Okay, it can hold twice that amount if necessary, but can burst if over-distended. And kind of a cool looking picture here. You can see the bladder, you can see the kidneys with the renal pelvis, and the ureters coming down. You could see a really great picture of the skeletal anatomy here as well. And more anatomy for you here to refresh your memory. UTIs, okay, could be simple as toilet habits, could be kidney infection from a kidney stone, okay. Urethritis, inflammation of urethra. Cystitis, when you see the cyst, it means fluid-filled sac, but when we see cystitis, it's bladder, right? The biggest fluid-filled sac, right? So inflammation of the bladder, pyelitis, pyelonephritis, inflammation of the kidney, dysuria, painful urination, urinary urgency and frequency, fever. These are all signs of a kidney infection. Urinary urgency and frequency is also a sign of MS too. It's a neurogenic bladder sometimes. Okay. Treatment, antibiotics can cure most UTIs. It's in my opinion, solid medicine to do antibiotics for UTIs. So there's lots of other natural medicine out there. Sometimes it works, sometimes it doesn't. Micturition is the fancy word for urination, okay, or voiding. So 3 simultaneous events must occur. So number 1, contraction of detrusor muscle by autonomic nervous system, opening of the internal urethral sphincter by the autonomic nervous system, opening of external urethral sphincter by somatonervous system. Reflexive urination, so like urination in infants, so there's a distension of the bladder, activates the stretch receptors, causes excitation of parasympathetics, so rest and digest, right? Parasympathetic neurons, in the reflex center in the sacral region of the spinal cord. So this is why when we adjust the sacrum, maybe someone that is incontinent, not babies, right, but someone that's incontinent or having bladder control issues, sometimes they get better. So reflex center in the sacral region of the spinal cord leads to contraction of detrusor and opening or contraction of internal sphincter. Inhibition of somatopathways to external sphincter allow for relaxation and opening. Pontine, so the pons. Okay, so the pons, pontine control centers mature at about age 2 and 3, between 2 and 3. So pontine storage center inhibits micturition, inhibits parasympathetic pathways, excites sympathetic or that fight or flight, and somatoefferent motor pathways. Pontine micturition center promotes micturition, so urine, excites parasympathetics, and inhibits sympathetics and somatoefferents. And you can see this nice pathway here. So urinary bladder fills, stretching the bladder wall, afferent or sensory coming from these stretch receptors. We see a simple spinal reflex happening here. So a decrease in sympathetic activity, an increase in parasympathetics. We see detrusor muscle contract, internal urethral sphincter open, and then there's urination. Okay. So maybe over here, sensory impulses from stretch receptors up to the brain, higher brain centers, allow or inhibit micturition as appropriate. Okay, so storage inhibits micturition by acting on all 3 spinal efferents or motor. So decrease parasympathetic, increase sympathetic, increase somatomotor or efferent, and then inhibits urination. Or they're like, yep, nope, we can urinate now. Now is appropriate. And so it goes through this pathway instead. Urinary incontinence in adults usually caused by weakened pelvic muscles, so pelvic floor exercises. So refer out to a PT that specializes in this if this is not your specialty. Stress incontinence, so increased intra-abdominal pressure forces urine through the external sphincter, laughing, coughing, sneezing, especially postpartum. Overflow incontinence when the bladder is overfilled and they can't hold it anymore. Urinary retention. So this is the most worrisome. Okay, so the other one is embarrassing, but this is worrisome. So unable to expel the urine. Okay, we worry about this with cauda equina syndrome. Okay, so general anesthesia, hypertrophy of prostate, catheterization, so they'll cath them. Okay. Developmental, 3 sets of embryonic kidneys form in succession. Pronephros, pro, kidney, degenerates, but pronephrotic duct persists. Meso, middle, kidney, claims this duct and becomes the mesonephric duct. Metanephros develops by week 5 and is what develops into our adult kidneys and ascends. And here we are. So look at this. This is the digestive tract. Okay. Degenerating pronephros, okay, urogenital ridge, mesonephros duct. Okay, kind of an interesting view here. And you can see the picture here as well. Metanephros here. Everything else. Metanephros develop as uritic buds that induce mesoderm, okay, mesoderm, middle, of urogenital ridge to form the nephrons. So distal ends of uretic buds form renal pelvis, calyces, collecting ducts. So the ureter ducts, proximal ends that will become the ureters. Kidneys excrete urine into the amniotic fluid by about month 3, and it's called the cloaca. Cloaca subdivides into rectum, anal canal, and urogenital sinus. And a picture here for you, metanephros, gonad, rectum, urogenital sinus, developing urinary bladder right here. Okay. Some common congenital abnormalities, horseshoe-shaped kidney. So the 2 kidneys are fused together across the midline, so it's really one. Okay, so when someone wants to donate a kidney, they can't because it's only one U-shaped kidney. It's asymptomatic. It functions just fine. You just can't donate half of it, though. Okay. Hypospadias, urethral orifice located on the ventral surface of the penis, corrected surgically at about 1 year old. Polycystic kidney disease, or PKD. Many fluid-filled cysts interfere with the function of the kidneys. It can be autosomal dominant, which is more common, less severe, or recessive and more severe. Okay, so it can be caused by defect in signaling proteins. Some developmental aspects. Frequent micturition in infants is due to small bladders, less concentrated urine. We see incontinence is totally normal in infants. Control of voluntary urethral sphincter develops with nervous system development. E. coli account for about 80% of UTIs. Untreated strep infections can cause long-term kidney damage. I had a patient once while I was a massage therapist, just a massage therapist, and they had had a kidney transplant because of untreated strep throat. Okay, so always refer out, or if it's within your scope of practice, depending on the state. In Illinois, I just swabbed them and looked for strep or not strep. If it's strep, refer out for antibiotics. If it's not strep, we don't usually worry about it. STDs or STIs can also inflame the urinary tract. Most elderly people are going to have some abnormal kidney tissue histologically. So kidneys are going to shrink, GFR goes down significantly, and the bladder shrinks, loss of bladder tone, nocturia. Okay, so that means frequent trips of urination at night. In men, you're going to worry about their prostate, but we'll get to that when we get to the reproductive tract, and incontinence. All right, that is our last slide for our kidney PowerPoint here. So go ahead and check out your quiz on Canvas, and I'll see you for the next chapter.